Now, when that
Yep.
when that happens, can you see my notes at the bottom or just the slide?
We can see the notes at the bottom.
All right, so let's just do. Can you see the notes at the bottom?
No, not this time.
Good, good, good. All right, so I mean, we could talk without the slides, but that's absolutely fine. So let me just introduce myself. So I'm Jane Turton. I'm the MND and Parkinson's shared care worker with the Southern Metropolitan Palliative Care Consortium. They haven't given me a business card for obvious reasons. Basically, what that is saying is that DHS know that MND is a very tricky condition, and they understand that the time that a person is in the palliative type stage of their disease is much longer than a run-of-the-mill, when I can say that, can I? A cancer or a heart disease, end of life. So what they want to do is to keep care staff like yourself as educated as possible so that we are providing expert care for these people. That makes sense. So when it says shared care worker, my funding comes a bit from the Motor Neuron Disease Association and the rest from DHS. That's the only reason it's shared. One day we will all come up with a title that actually makes more sense than what it is. All right, so I'm going to talk about motor neuron disease today, and I just want to give you a little bit of an understanding of what that actually is before we launch into looking at some symptoms, okay? It's the name for a collection of diseases that all involve the nerves or the neurons that go from the brain down the spine to the muscles. So there's actually nothing wrong with the muscle at all. It's just that the impulses and the messages from the brain are not getting to it. So what will actually happen is it will become weaker and then it will actually waste away. So most people will be saying, how can I exercise these muscles to make them bigger and better? You can't. It's the nerve impulses that are doing it. So these nerves, the motor nerves, are actually the nerves and nervous system that goes to voluntary muscles. So these are the ones that we are able to say, straighten your arm or move your arm. It's not the muscles of the gut, that is perfectly intact, but it's the muscles of the jaw, the muscles of the swallow, okay? And that will come a little bit more apparent as we get on and talk about the symptoms such as swallowing and talking. Okay, and also the muscles that are in between your, here am I pointing to my ribs, you can't see that, the muscles that are in between your ribs, that's those muscles, and then the diaphragm, which is one of the biggest muscles of the body. You can actually say, I want you to contract so that I can take in a big breath. It also has got involuntary neurons going to it, obviously, so that you continue breathing overnight. Makes sense. Okay. So we know that mobility and breathing are impacted, but taste and smell and sight and touch don't. So this person can actually feel you touching their skin, yet they're completely paralysed, unable to move an arm or a leg, for example. Now, when it comes to a cause, if we knew the cause, we would not have MND. Sadly, we do. For every person that is diagnosed today, there's generally someone who passes away. It's very static. However, that in Victoria in itself, and I think we've got something like 751 people at a time, and am I saying that Australia, not Victoria? For every person who passes away, another will be diagnosed. But since our population is expanding, we're getting more and more people being diagnosed. We don't know what causes it, but there are theories out there that talk about toxins and toxins that are neurotoxic to the brain and the nerves. There's a big theory on cigarette smoke, diesel fumes, but we also don't know why someone might have a gene, and we do know a few genes. Nothing turns that gene on to develop MND, but other people, there is no reason. There's no rhyme or reason. What I've looked at for eternity is that when you meet these people, and I'm waiting for Liebert to say, yep, that's correct, but when you meet these people, they are odds on lithe. They played sport in their previous life, generally sport that involves an irrigated field. And they tend to be those people that come with a beautiful halo, that they're just those glorious people deep down. Are you nodding? Yeah.
Yeah.
Yeah. That's why I say I'm never going to get this, because I'm not nice enough for it. Okay. Absolutely true. Now, you may have heard of it being called by other names, such as Lou Gehrig's or ALS or progressive muscular atrophy or progressive bulbar palsy. They all come under the umbrella of MND. Okay. It's considered not a rare disease. It's considered to be uncommon. Okay. And there are GPs out there who in their entire career never actually see anyone with MND. So your agency having 2 people currently with it is actually quite big numbers. Yeah. But I also then have to say is that when someone is diagnosed and when they go onto a home care package, people such as myself and those that work down at Bethlehem, if we have known that this agency has had people in the past, then we tend to often say, why don't you contact them for a home care package when they've been approved? Okay. In Victoria, we've got Calvary Healthcare Bethlehem. So your patients live, I presume, and I hope, are already tied up with them.
Yeah. That's where we got it from, like for the MND association. Yeah.
Good. Excellent. So I'm going to put it to you, and Leva, don't jump in. You've got colleagues there, but do you know what these symptoms are?
What the client has?
Yeah.
He's more the breathing and slow speech now is becoming, more
harder.
Yeah, harder to hear him, understand him. You still can, but he's slower at it.
It's harder.
But he's more concerned with the breathing now. Yeah.
And so, look, the breathing is one of them, and I've put some symptoms there for you. And it actually just it's determined the symptoms that they exhibit, and I'm presuming that your 2 patients that you've had presented quite differently.
Yeah, like the other lady, she communicates via whiteboard. And she is reliant, on a hoist and things like that. So
and difficulty swallowing as well.
And the swallowing difficulty as well. Yeah, more so than the respiratory.
Yeah, and if you've ever looked at one of our top ex-footballers that does a lot in the way of raising the awareness of MND, if you look at him and his symptoms, they're quite different to what your patients have experienced. Yeah. Okay. So there's some of our the symptoms that we often see with people. All right, let's start at the top. So we're going to talk about speech to start with. So if you picture the muscles of your jaw and the muscles of the throat are all needed to coordinate your lip, which is an enormous muscle in itself, and the tongue and the larynx and pharynx, in order for you to get food down and also for you to make voice sound and words, okay? When you go to speak, you don't even notice you do it really, that you take in a big deep breath. So that's, again, relying on your diaphragm. So if you've got weakness from here and the diaphragm, number one, you can't take a big breath to expel air, which is making your words. And so your voice starts to become a whisper or even a mouth moving with no sound coming at all, okay? You also don't lose sight of the fact that when we communicate with a smile. Or if I said to you something that was not so pleasant, you would do this. So all of that non-verbal but facial expression in a communication is also hindered. So you might have someone trying to tell you something really, really important to them, but they can't make the face look as if they're getting a message across, and they certainly can't make the sounds to make a voice, to make words, okay? So where it comes to, here's me just talking and forgetting to move the slide along. When we can't communicate, and you picture the lady with her whiteboard, it becomes incredibly isolating. It means that they will say, well, I'm not going to my social group anymore. I can't talk. I love talking, but why would I go? Frustration and anger is huge. And anxiety of, if I can't get my food down or my words out, how am I going to tell you what I want done? Or how can I tell you that there's a stone in my sock and it's hurting my foot?
Mm.
And it's an incredibly isolating and distressing time for these people. Okay.
Mm.
So what we can do about that is, the last thing you want to do is neglect the person. If you're going in to provide hygiene for this person, the worst thing is that you walk in the door, you tell them all about your weekend, because while you're talking, you don't realise that they can't talk. You've gone in, you've showered them, you've put a load of washing on, you've given them their breakfast. They now know entirely your week's adventure that you haven't even been able to get across. Do you want to wear those socks today? Or do you want to wear that jumper today? What would you like? So we're going to encourage them to just slow down and speak, and very, very carefully just take their time. Let them know that you've got all the time in the world to hear what they've got to say. Face them. Don't be so looking over here and being distracted by the cat sitting over here. Just be present for them at that stage. Reduce the background noise and then you might be able to hear them better. Don't interrupt and finish the sentence, because when you look back on that, you realise that you've jumped in with 17 different options for the end of that sentence, when in fact, if you'd given them 2 more minutes, they would have got the whole sentence out for you.
Mm.
Everyone who goes down to Bethlehem will be given some sort of device that allows them to communicate freely. If they're able to type, they might be using a little typewriter called a light writer that they sit and type here, and on the back of the machine you can actually see what they're typing out to you. If they can use a pen and paper, they might have a little boogie board which looks like an iPad, but it's like one of those Magnadoodles. If they can use the whiteboard, perfect. Okay, but allow them to write the whole sentence. Okay, and then of course establish the gestures that mean yes and no, and ask questions too that give you the yes and no. So have you got the right jumper for the day?
Mm.
So you said to me a few seconds ago you've seen the whiteboard. Have you seen any other methods with any other patient as well to help them communicate?
The boogie board, she had that as well, the one you mentioned, but she just had that because I went there today, so that was sort of new for her. Yeah.
Good, good. Do you get the shared care plan from the staff at Bethlehem?
No.
It would be useful for you if you've got a contact name of your 2 patients, if there's a contact name for either of them, it would be useful, with the patient's permission, of course, to ask for the shared care plan.
Oh, yeah.
It's written up after they do all of their appointments.
Yeah.
And it will say things like, this person's having constipation, this is what we suggest you try, and this is when we think it will be resolved, or this is what we want you to do. Where it comes to feeding, if they're going to have some peg feeds in particular or supplements, that's going to keep you updated with which supplements they suggest. So it's just another way that you can keep up to date with what the recommendations are.
Yeah, that's a good idea.
So one of the things that when a person is obviously presented with their symptoms here, and we know that they're going to lose their ability to talk, they can be set up on what we call an eye gaze. What it basically is, it's a computer attached to their wheelchair. Their eyes are calibrated to the screen and they look at the letter and spell out the words. And then they can push on, gaze at another little dot, and that then will speak the word out. If they've been very proactive in doing this device for themselves, they can actually voice bank. So that before they lost the ability to talk, they had recorded hours of words and phrases in their own voice, so that when they no longer can speak, they can use the eye gaze with their own voice. It's very, very sophisticated, but that's something you might see at some stage. Other people can have a laser attached to a headband, and they can shine the laser on letters that are on a board in front of them. And then also using alphabet boards and boards that have got phrases and everything on it as well. But every person who's come from Bethlehem will have something like that for them. Okay.
Wow.
Yeah,
very
good.
Sophisticated.
Yeah.
Her arms are going now. So I'm like, well, what are you going to do when you can't write anymore? I was thinking that today. I was like, oh, so that's good to know.
Yeah. Look, there's, I know of one gentleman who has got no movement whatsoever. He uses the eye gaze, and not a sound comes out of his mouth, but he has written stories. He's done all sorts of work using it. Take away the eye gaze and he's got no ability whatsoever to communicate with you.
Mm.
The staff, and look, here's my next slide, but the staff at Bethlehem always are proactive and will always be working ahead of the person's ability, so that we don't ever get to a stage where someone is in a position that they cannot communicate anything.
Mm.
Okay. So, you know, if you are concerned about the communication and trying to get, you know, thinking ahead, you know, you always speak to the speech therapists and occupational therapists at Bethlehem. Okay, they will always be finding something better.
Oh, good.
Yeah. Right. So I have put this here. I'm just praying you're now going to see an eye gaze. Okay, so it's just a little video. If you can't see it or hear it, can you hear?
No.
All right. So they warn me that this may not happen. So this is Jeff Woodrow.
Oh no. Sorry.
This is him typing out his message. You can see up in the top there.
Oh, yeah.
And then he's then clicked on the button that actually reads that out to you.
Yeah.
So you can see him moving his head and moving his eyes.
Mm-hmm.
That's how he has been typing out that keyboard.
Oh, wow.
Very cool. Yeah.
So if you were ever using this with somebody, you would just give them the time. Expect some terrible spelling errors, but basically just stand back, give him the time, look to his face while you're speaking. Certainly don't be looking over his shoulder and just reading it, because he's able to make it speak to you. So you just would get into the swing of waiting for him to type, and click on speak. At the moment, he's just reading all of that out. So have a read.
Wow.
So he can email his friends, he can chat to whoever he wants. Yeah, he's not hearing impaired. He's just unable to speak, so we will communicate another way. If you were showering this gentleman, you would need to make sure that you've got all your chatting done before you actually take him out of his wheelchair and away from his computer, because then you will be relying on yes, no. You know, is the water too hot? Is the water too cold? Yeah, it's pretty impressive.
You'd be the one doing all the talking.
Sorry?
You'd be the one doing all the talking throughout the shower.
Yes, you will be. You will be.
Get all your weekend story done at that time.
That's right. Now, let me see if I can make this move on. No. There we go. Good. Right. Yeah, look, it would be. You would have to ensure that, you know, Mr. Whoever, and he would get used to the fact that the only conversation that's going to happen while he's in the shower is, you know, is the water hot? Blink, blink. Yes, it is, or it's too cold. And he'd be used to that. Put him back in his wheelchair where he's got his machine in front of him, and then you'll hear all about his week. But while the communication board is away, you've got no hope at all. Okay. So let's move on to respiratory symptoms. So as I said, it's the muscle of the diaphragm and the muscles in between the ribs that do become weak as well. You will know that your patients will be going down to Bethlehem regularly and doing lung function tests. I try to say to facilities when they've got a person as a resident there that please don't ignore that. They will have done a lung function as they were diagnosed, and they will do it if it's every month, every 2 months, whatever it may be, just to actually watch what's happening with the amount of oxygen. So their forced vital capacity, which is the bigger breath that they can take, they'll be watching what happens with that. If it gets to a certain point, I should actually say when it gets to a certain point, they do start talking about ventilation. Okay. Do either of your two patients use a breathing machine?
Yes.
Yours
They
does.
both have.
Yeah, no, just one, I think. Yeah.
Yep.
Yeah, a lot.
Yeah, so it's not something that they're given the machine and told just use it overnight. It will evolve into them using it during the day. And if you are in the home and you see that they're really, really exhausted, they're fatigued, the eyes are closing, you may suggest sit in your recliner, pop your machine on just for an hour. It just gives you a little bit more energy to keep doing what it is you want to do during the day. Okay, so there's no prescription that says you only use it for this many hours. It's going to evolve. And some people, very sadly, will get to a point that they can't take it off.
Yeah.
Yeah. Yeah. Okay, so you watch for things like them waking up and saying, I've got a rip-roaring headache, or I was so restless. I woke up 20 times overnight. I can't get comfortable. I need to have a nap, or as soon as I have breakfast, I need to nap again. And these are all symptoms that are indicative of them not being able to take in a good enough breath, so that overnight, when we all breathe much slower and more shallow overnight, but they get to a point where they're breathing so shallow that their carbon dioxide levels are too high, and that's their body waking them up to say, take a big deep breath. That's why they can't get into a deep sleep. Okay. So there are exercises that they can be taught, again, by the physios at Bethlehem, one of them called breath stacking, which is an exercise, and I'm not going to go into it, to basically try and open their lungs and also expel any secretions. Yeah, saliva goes down into your lungs, and the lungs make secretion anyway. If that is allowed to pull, we don't want chest infections happening. Okay, and you'll find too that you might be talking to these people and they'll be doing that, trying to just clear their throat because they cough. They can't take the breath in to make a big cough and cough it all out. That makes sense?
He has trouble coughing.
Yep. Yeah, and that's again where I want you to communicate with Bethlehem and get that shared care plan, because on that, it's going to tell you any exercise he's been given to try and expel secretions or make a big cough to clear his throat. Okay. So, I've listed some things here that are indicative of the respiratory changes, which is, as I said, the sleep and the headache, sleepiness and fatigue. You can see when someone's using those intercostal muscles and trying to get the breath in, and that's when you can know that the breathing's not good. Again, encourage them to sit with the machine on for a bit more. Okay. If they start getting to a point where they're using that machine for about 16 hours a day, the Austin Hospital, which look after the ventilated patients, they'll actually send out another machine. It's there purely that if one breaks, we don't want the person coming a cropper because they haven't got their ventilator. And they'll also have a battery backup power too if they turn the power off to the house. That makes sense?
Yeah, it's good.
So down to swallow, obviously I touched on that a little earlier, that, when you put something in your mouth, you chew it, and that's the muscles of the jaw. You add saliva to it to make it a bolus. And then your tongue, which is a big muscle, it just pushes the food to the back of the throat, and then the throat muscles swallow it all down. Okay? If you can't make that tongue move, then how are you going to get that food to the back of the throat to swallow? So your patients may well be having trouble with their swallow as well. If they're having trouble speaking, I imagine they can't swallow very well. And it might be that the dietitian at Bethlehem has actually said to them, I don't want you eating mixed consistencies. So I don't want you eating a steak and mashed potato. I want you to eat mince and mashed potato, all the same consistency, just so that your muscles aren't going to be struggling more. And they will then say, all right, I want you now to be eating more of a pureed diet. Or they may well have said, it's time to put that peg in, a feeding tube. Okay, you know what I mean by the peg?
Yes.
Good. Okay, so dysphagia and swallow there. The saliva also becomes more of an issue as well. If you can't close your lips completely, Is food going to dribble out? Is saliva going to dribble out? And that's just really unpleasant, isn't it? Okay, so the drooling is something that makes people retreat and stop going out with their friends. If you're not going to get the food and fluid in that you actually need to be healthy, then we're looking at dehydration and malnutrition. But more importantly, if you are trying to swallow and all of this mechanism here is not working, then are we going to get food down into the lungs, which will end with a choking risk or an aspiration. A lot of these people will say their number one issue in life is the thought that they're going to choke to death.
Yeah.
Very few people ever do, but it's the aspiration that often ends people's lives. Okay. Back on the saliva talk as well. If people are starting to say, you know, I just drool and drool, I'm making so much saliva, it's not the body making more, it's just that you and I will swallow when we feel that I've got a mouthful, and you don't even notice you're doing it, but they don't do it at all. So as I said, it might start leaking and drooling. There's medication that they can take to dry it up, but it's a bit of a seesaw. If they take too much, are they going to be then saying, my mouth is so dry, I feel like the cockie's cage? Some people have had Botox to their saliva glands. Again, you understand that's going to be good 3 months before that they start making it again. And is that going to be 3 months of being really, really dry? It's very difficult to find someone in Melbourne who will do that, but it has been done. Some people actually say to you, I feel like my mouth has got saliva that is so thick I could pull it out like a rope. Okay, and that's where they start feeling, I can't get my breath because it's in the back of my throat. And they're often suggested to have some papaya tablets or pineapple or dark grape juice. It's got an enzyme in it that will actually break those secretions down. But then also being aware that if a person is really struggling with swallowing and they shouldn't be having thin liquids, please don't be giving them pineapple juice or papaya tablets because they're going to be more of a choking risk. All right, swallowing and dysphagia. It's very much a multidisciplinary review. And down at Bethlehem, the speechies, OTs, dietitians and physios all work together to come up with a plan that is going to be the safest and best option for these people. Okay. No one is forced to have a PEG put in, the percutaneous endoscopic gastrostomy, but it is always put on the table when we can forecast that someone is going to actually need this for all of their nutrition. Many people will say over my dead body, and that's absolutely fine. It sadly would get to a point that if they are that malnourished and dehydrated, that medication is what's the best option, but it's often very much the end of life. Okay. So look, that's a shocking picture, and I might try and get a better one later, but basically this is the PEG tube. The way it's done nice and easily is with a bit of twilight sedation, and they all go in at the Austin. If a person leaves it till their lung function is quite poor, they may have to have the tube done under X-ray guidance. It's harder, and if this person can no longer lie flat, because remember when you lie flat, your stomach contents push on your lungs, it's harder to breathe. So if they can't lie flat and they've left it to a certain stage, then it's potentially, they're told it's now too late. Okay, and that's a very sad thing when someone has left it too late. Okay.
Yeah, one of our clients, they tried and they couldn't do it, but I thought it was more of a placement thing, like they couldn't pass it.
Yes, so
but yeah, I'm not sure.
There are many. Yep, there are people who have gone off to theatre saying, yep, I'll have that PEG, and they've realised that their stomach is actually behind some intestines, so it's physically impossible. People have gone off to have the PEG done and sadly come out of the anaesthetic, the twilight sedation, with a diagnosis of cancer of the stomach.
Oh.
And then it's happened. And also people, if they have had things like gastric banding, It's
A hiatus hernia, because
hiatus hernia, if it's a really bad one, yep.
she said to me that that's
Yeah.
one of the reasons as well.
That's what
Yeah.
I thought too. That's what I sort of thought she
Told
meant.
me that. Yeah.
Yep.
Mm.
Yep, absolutely. If you know, the hiatus hernia is when the stomach has migrated up into the chest cavity.
Yeah.
If that one is if that has left very little of the stomach outside of the chest cavity, then they won't find a place to put it in.
Yeah.
Yeah, yeah. So look, I'm glad I put that picture there then. All right. So talking about mobility, okay, depending on where this appears in your body. So when we were talking about our footballer a little while ago, that started in his legs. He is possibly not particularly walking now, but it started in his legs and then into his arms. It's progressed to a point that if you look at him when he's being interviewed, no one will ever shake his hands because he can't move his arms. You know, the ice bucket challenge they've done, the big freeze, at the MCG. And when you watch it happen and he pulls the lever to make the person fly down the chute into the ice, his hands don't do it, somebody else's hands. So that's where it's presented in him. And that's why he's had it for close to 10 years. Whereas the ladies that you've talked about who their first symptoms are here, they've gone off to their doctor saying, my neck hurts, my head's fallen forward, or food just keeps getting stuck in my throat, or my voice has changed. People are telling me my voice is different. When it starts here, you can imagine, you know, my swallow, my aspiration pneumonia, my speaking, and this is where you get a very short prognosis. Okay, so where it comes to mobility, the neck weakness, when it's when it started here, or the upper limbs, lower limbs, pain isn't particularly a big issue with MND. They can still feel pain, and it tends to come with stiffness and the pain that you would get when you're being really immobile, and hopefully not pressure sores. But that's where mobility is impacts people in particular. Where it comes to equipment, and these people tend to use an enormous amount of equipment, whether it's a wheelchair, the shower chair, a hospital bed, the breathing machine, and you'll see all sorts of equipment. A lot of this can come on loan from the MND Association. Okay, so you may find that some of that equipment in your patient's houses has got a sticker on it already. So if you were thinking this shower chair is broken, or we need something different, the OTs at Bethlehem can organise that through the MND Association, as long as the person is a member there. Okay. Next slide. All right, so the respiratory symptoms we touched on. If the person is using the machine and they're looking fatigued, they're still waking with a headache, it's just all too much, pop the machine on. If we are getting to a stage where the machine is on for a lot of the time, then we can organise some low-dose morphine. When I say low-dose morphine, I'm not saying that this is the end of their life, but low-dose morphine is very good for that feeling of anxiety when you can't catch your breath. If they are saying to you, I'm just fatigued, sitting them upright, and they will all have a recliner that alters their position. Sit them upright in the recliner, okay, or sit them more upright and stop letting them slump down, okay. The weak cough, as I said before, they can be taught breath stacking exercise. That's where they'll take 2 breaths and try and have someone help them cough it out as well at the same time. Okay. I should also at that point say that the NIV machine is not a CPAP. Okay, it's actually varied levels of pressure or bi-level of pressure. CPAP will just pump air at you continuously, but the NIV, you'll hear it go puff, and then you'll hear the person breathe out, and then it'll puff again. It's been carefully titrated to that person's body. It was initiated at the Austin, so they will have had the person come into the Austin, sit there with various masks and various levels of air, and until they found the right one, and then they'll go home on the machine. What is really interesting is the number of people that are sat in the chair, put the machine on, turn it on, get the right levels, and they promptly fall asleep because they've been desperate to get into a deep sleep. It's a bit sad. Yeah. All right. You will also find that people who say outright, I'm not having a PEG, it's when they never pursue doing the breathing machine. Okay. And the reason why is that we don't want a person to get to a point where they can't take the machine off to eat, basically, which is, it's just too distressing. Okay. So if you've got a breathing machine in a person's home, don't ever adjust the settings yourself. In fact, most of them have got a lock, so you can't. The one thing to look out for, though, is with the mask, and I think I've got a picture of a mask. Have I? No. With the mask, they'll generally have two different styles. What happens, though, when they've got a full mask and they're starting to really struggle and they know that nothing is helping, they'll often tighten the straps. And before you know it, you've got a pressure sore on the top of your nose. Okay. If that were to happen, the Mepilex light will fit nicely over the bridge of a nose, but also you use a different mask, which is still just as good, but just will relieve the pressure on the bridge of the nose for a while. Okay. Don't hesitate to contact BRSS, which is the Austin Hospital, if you do want to have a try of a different mask for your patients. Okay. Next one, pain. As I said, it's not really a condition that comes with MND, but the pain that you do feel is the cramping in the muscle and the legs, the spasticity. So you might see the muscles actually really clamping down and the person will say, oh, my leg, it hurts. You know, some massage and trying to stretch the limb out for them will always help. Okay. Pain and stiffness in the actual joint, especially if you try and lift someone under the arm that has got the weakness in their shoulder, you will dislocate the shoulder because those muscles are no longer holding limbs in place. And once the muscles wither away, there's very little holding the shoulder joint in particular to be in place. There's a little bit of pain in the muscles due to a loss of a normal posture. Okay, and you also will find people will say their legs are hurting because they've got edema, which is like being in a plane for a 24-hour flight, isn't it? That you don't wiggle the toes, then you'll get the pain. Okay. With all of these patients, and it might be a good idea for you to have a bit of a chat to these two, is that the MND Association actually have what they call their top-up funding. It's $2,000 each year, which is not to be sneezed at. And for a lot of people who are finding that pain and the spasm in their legs is an issue, a lot of people will have a massage and book someone to come to the home for a massage once a month, once a week, whatever they want. Have a chat to them. If they don't know anything about top-up funding, then either get back to me or get back to their advisor from the MND Association. And that's that person's name you should know.
Okay. Yeah.
If you don't, we'll work it all out.
No, I know.
But the top-up funding is try and think of something that's going to add quality to your life. I think the last one that I put the application in for was a man who wanted all of his family to go out to a restaurant and wanted, you know, the multi-purpose taxi. So we paid for the multi-purpose taxi and all the food for his whole family, $2,000. Another person got, and this is, I'm going back 15 years, Foxtel, so that he could sit and watch his favourite movies. And massage is a big one. Yeah. A young lady, sadly, who's got little kids, she wanted a cubby house for the kids to play. And others have actually said, I want meal delivery just for a little while to have a bit of a break. So it's not dependent on any one person saying you can only have this category. Like, get them to think laterally. There's some great things they've done.
That's awesome. Thank you.
Yeah, follow it up. Let me know if there are any concerns or you do come across something. Pain management. I've never actually said to anyone, take the tonic water because of quinine. It might help. Drugs, therapy, absolutely. Some Valium, baclofen, the gabapentin and the dantrolene for spasticity. They do still come with side effects, but you know, it's worth having a try. Again, massage and stretching. So if you're at the person's house when they're saying my leg hurts, feel free, get the moisturizer, give them a really good rub on the legs, try and just break that spasm. What else have we done? So, electric beds and tilt-in-space wheelchairs can actually change position. So if they're starting to feel sore on their bottom, and let's prevent pressure sores at all cost, change their position and see if that will help as well. Okay. But again, as I said, the top-up funding is fantastic. Okay, secretions, which we've talked a little bit about. The first thing that people try and do when they feel that they're just drooling, and as I said, they'll say to you, I just make so much saliva. They're not. So just do a double take that they are actually drinking enough, because it makes sense to some people that if it's all pouring out my mouth, then if I don't put it in, then it won't pour out, which doesn't really work. The papaya tablet can be sucked. Or a mouthwash. The juices, you can make the dark grape or pineapple into a slushy if they hold it into their mouth, hold it in their mouths a bit more. A lot of these people will have saline nebulizers as well to actually help try and break up those thick secretions. If they've got a peg and the secretions are becoming really thick, then by all means put some more water down the peg. Make sense? Good. Again, it's such a seesaw. What you do for one thing might lead to excess secretions. Treating that with medication can lead to having more of a dry mouth. The dry mouth, if you swab it with water or some of the over-counter Biotine products, or peppermint oil or sucking ice, can actually feel you a little bit more moist. Obviously, reduce caffeine and smoking. Please don't let them smoke. And just increase fluid to stimulate the saliva to be made. Okay. Yep, I've put a lot of the medications there. I don't think that this is all that appropriate just at the minute. If you're not going to be prescribing anything, let's move on to emotional ability now. If you've got a lady whose symptoms started here, I suspect that she's also demonstrating more a pseudobulbar effect, which is when, if you say to them, did you watch Married at First Sight last night? Which most people would go, oh my gosh, and she might just burst into tears. So it's not the correct emotion that you would see. Or she might say, my grandson came yesterday, and then dissolve into tears. That's a pseudobulbar effect, okay? It is unpredictable, uncontrolled episodes. They may laugh, telling you a really sad story, but that's what it is. You tend to find those people will either giggle along with it, or they'll become so distressed that they can't rely on themselves to be speaking suitably, appropriately when they go out. So they may well start staying at home more. There is medication that the GP or neurologist can prescribe. Again, it might be more of a situation that you need to feed this back to your contact at Bethlehem, that this is becoming more of a concern or distressing to your patient. Now, in the olden days, and I'm allowed to say that, they didn't believe that MND came with cognitive changes. As research has gone on, they now start to feel that MND and FTD, so frontotemporal dementia, is on a spectrum. There are people who have been diagnosed with MND after they've been given a diagnosis of FTD, and then there's other people up the other end of the spectrum that just purely have motor neuron changes, and cognitive changes not changed at all. So it's not that I'm saying you are going to see people who start to forget things. No one is going to forget they're in a wheelchair and try and stand up. What you're going to start seeing is just the odd comment that is a little bit more, what's the right word, limiting, that, they've just become a little less self-aware of what they're saying to you. Okay, so it might be that it's all about them and they're just totally disregarding that somebody else is in distress. They may well become more, as people would describe, as eccentric. Okay, and that might be that they say, well, I've got to get these muscles going again, so I'm off to the gym. And it's that type of eccentricities. But there are people whose cognition will deteriorate to a point where they no longer have the capacity to be making their life choices. Okay. It's more often associated with those people who have the bulbar onset, and the bulbar onset is the neck and the upper motor neuron features. It does tend to indicate that it's going to be a shortened lifespan, and obviously there's additional carer burdens. These are the people that we see are going to end in aged care facilities before somebody who's got it happening in their legs, perhaps. So, you know, again, it's the lack of concentration. They no longer can learn new things. They're never going to learn how to use an eye gaze. They've lost the ability to even type anyway. And they've also lost the insight into knowing what their condition is causing, or even what it is. They might become impulsive, and they might become what we call a rigid thinking, that you're never going to take them away from going over and over in their mind about, you know, what they're going to have for lunch. So they're difficult people to manage. With them, try and use the distraction and diversion if they are very much just focused on lunch. It's harder on the family. You're going to be looking at getting more carer support in, and it may well be that your top-up funding is for carer support, but always ask. But always, if you are starting to have concerns that this person has got some strange behaviours or strange thoughts, let the people at Bethlehem know, because you'll be seeing these people every day. They don't. They may only see them every fortnight or every 2 months or so. Okay. All right. So now tell me, I'm hoping that there's something that you've picked up on today that you think, I'm actually going to do that a little bit differently. Is there anything coming to mind?
I think I'll be a lot more aware.
Yeah.
Definitely, like, not definition sentences, that's bad. But I think just a lot more aware of, you know, the things that can help as well. You know, especially I see this saliva thing happening, and, you know, it's good to know that there's, and the Bethlehem, the shared care plan. Oh my God, how good is that? And the top-up funding, like, I just learned so much. Yeah.
Good,
Sorry.
good.
You go.
And look, I probably didn't say it, but where it comes to the saliva, you know, people will say, get me a suction machine so I can suck it out. But what you find is that if you put whatever you put into the mouth, the body's first response is, oh, it's got to be food, so I must make more saliva. Yeah. So you can actually drive yourself mad and hurt a person by continually sucking it out. It is more a case of what can we give you to dry it to a point where it's manageable, without getting to a point where your mouth is now dry and cracked and painful from no saliva at all.
Yeah.
And then there's sort of, are you at a point that you're going to get some, for want of a better word, you know, some adult bibs that are not baby bibs, so that his clothing is clean and he feels clothing protectors. Yeah, how could I not come up with that? But yeah, just, you know, some sort of protection so that he feels or she feels, you know, dignified, and she's not going out with food all over her, and people aren't, you know, constantly worrying about what's coming out of the mouth.
Yeah.
So top-up funding, most definitely. You know, feel that you can make decisions about the NIV. If they're weary, then encourage its use. Definitely get that shared care plan. Each person who goes to Bethlehem sees potentially a different neurologist, and each neurologist has got a clinical liaison nurse who is the overseer of all of those patients. She's the one who will be doing this shared care plan for you, and to get her name, and it's possibly 2 different people for your 2 different clients, but, you know, it's an up-to-date suggestions and recommendations. They do it so that it goes to the GP, it goes to the MND advisor at care agencies or a nursing home, or other specialists that are involved, palliative care team, so that everybody is all on the one page and no one feels that I won't talk about nutrition because I'm not a nutritionist, a dietitian. Whereas if you had the care plan, you could say, well, hang on a tick, Mr. Smith, you actually should be doing 3 supplements a day, and I'm here for breakfast, so why don't we do a supplement?
Yeah.
Yep. Okay. So I also put the slide here on our webpage. So the Southern Metro Region Palliative Care Consortium, we've got quite a few webinars that someone has recorded a couple of years ago on various topics of MND. We also do have some documents that you can get on our website that talk about MND in palliative care and also MND in aged care facilities. But also, if you go to the MND Victoria website, you can download a book called Aspects of Care, and that will also go through it all again with you, and that's totally free. But above all else, if you do have any concerns with your patients with MND, just give me a call. Happy to talk through or problem solve with you.
That's so nice. Thank you. It's really
You're welcome.
lovely.
Do you have any questions?
Leva, do you?
No, I think, yeah, that's a lot to take in, but yeah.
I feel much more prepared now, though.
Yes,
Yeah.
just to,
Good.
be aware and observe, and, if there is anything that I feel, oh, I'm not sure about that, I know I'll think about it.
Look, I agree. I think it's, if you're seeing this person day after day, or you've got carers that are going in day after day, you're going to be the first person to see the change.
Yeah.
The people of Bethlehem rely on you. So the conversation might be, hey, Mr. Smith, I'm getting a little worried. You look like, to me, you've lost a bit of weight. Are you happy for me to just speak to Marianne, your liaison nurse at Bethlehem, and just run it past her? Is there something else we can do for you?
Yeah, perfect.
Yeah, so I think it's lovely to know that you're not on your own. It is part of
no, never think you're on your own.
Yeah.
Never at all. These people are very complex. As I said right at the beginning, these people are generally amazing, lovely people. And, the whole goal is to ensure that they get quality care from agencies that are able to provide carers that are confident and happy to continue. The last thing we want is you to pull out because things look like they're getting rough or we're not managing him well. And we don't want then have to introduce new people.
No.
Wouldn't do that. I'd be wanting to know, where he can get the help and where I can get the help.
Yeah. Look, the other thing too is that Bethlehem Hospital actually moved back to their Caulfield site last week, the week before. If one of your patients, the carer is starting to look a little weary, there's nothing wrong with suggesting some respite down at Bethlehem. And going down there, he would be cared for by nurses who are fully aware of MND. And it might just be that they can do a tweak to his feeds or the machine, the breathing machine, or, heal a pressure area that's breaking out, or try and manage some pain or the cramping in the legs better.
Yeah. Thank you so much.
Yeah,
you're welcome.
Thanks, Jane.
Lovely to have met you all. And again, there's my phone number down the bottom if you want to jot it down, or Hildy's got my email address and phone number. So please be in touch if I can be of any help.
Yeah, good. Thank you.
Well,
You're welcome.
Thank you so much, Jane.
You're welcome. Lovely to meet you all.
You too.
Okay.
Bye.
Bye.
Bye.